Okay, well, we'll go ahead and get started. Welcome and good evening. Um, uh, Welcome to the ACFAS Virtual Journal Club for the month of February. Our topic this month will be functional limb salvage. Um, uh, this month we're joined by the fellowship from MedStar Georgetown University Hospital Foot and Ankle Research Fellowship in Washington, D.C. Certainly, tonight's topic is one that is very pertinent to all of our practices, I think. Uh, Before we get started, I just would like to take a moment to recognize the generosity of PICA in supporting this month's Journal Club. The PICA representative joining us this evening is Dr. Roland Ramdas. Dr. Ramdas is a board-certified foot and ankle surgeon with more than 2 decades of clinical experience and academic leadership. He serves as fellowship director for the Nova Foot and Ankle Fellowship and sits on the board of directors of the American Board of Foot and Ankle Surgery, where he contributes to national standards in surgical training and certification. He has served in executive roles within the Virginia Podiatric Medical Association and contributes extensively to examination, clinical, and education committees. Dr. Ramdas, thank you for being here this evening. If you'd like to say a few words.
Oh, great. Thank you guys for having me. That's too long of an introduction. I'm just a guy who loves to do foot and ankle surgery and loves to keep our patients walking. So it'll be interesting to hear about this research tonight that talks about patients who have lo lost their limbs and how we can keep them active. So thank you guys. Happy to be here.
Well, certainly, and thank you, and thanks to Pica. Um, Next, I would like to introduce this month's host fellowship program with fellowship director Dr. Jayson Atves and his current fellow Dr. Bilal Louzati, again from MedStar Georgetown University Hospital Foot and Ankle Research Fellowship out of DC. Welcome.
Yeah, thanks so much for having us. Very excited about the topic and honestly really excited to kind of talk through these articles as well. I think, as has already been said, very pertinent to all of our practices and certainly pertinent to all of our patients and their lives and lifestyles.
Thank you for having us. It's excited to get through these articles, everybody. All right.
Great. Well, if you wouldn't mind sharing your screen and basically how we'll format this is working through the first article. We'll just do a brief summary of the article, and then we can kind of work through a critical appraisal and some discussion around the article, and then we'll do the same for the second and move through these topics. So thanks.
All right. Let me know what you guys see here. Let's see.
Yep.
All right. Everybody have that main screen up?
Yep.
Awesome. Okay. So our first article here, we're looking at clinical measures of balance. Let me get this out of the way here. Balance gait cannot differentiate somatosensory impairment in people with lower limb amputation. This is by Peterson et al. It's out of Pittsburgh. The question this article asks is, can clinical balance tests detect sensory impairment severity? A little bit of background. Lower limb amputation patients are high-risk patients, as we know. As we look at that specific population, there's there's a little bit more worry on differentiating between the sensation in this population and whether the tests that we do in our clinic to determine their ability to, perform gait after amputations is being assessed correctly. And that's kind of what this article looks at. Like I said, the background of it is the somatosensory part of things, your proprioception, your feedback that you get is real important because it determines the patient's ability to stay stable and thus avoiding our fall risk. All right. Okay. So this study, level 3 cross-sectional observation study, it has 20 amputation patients separated 10 by 10 and 10, impairment versus sensory impairment versus non-sensory impairment or intact. And then it matched them up to 20 able-bodied patients they were matched based on gender and age. Those are the two categories they looked at. And then they looked at their motor control test, which is essentially just a reaction to sudden platform shifts. And then they looked at their this version of this is our sensory organization test. This is the only kind of image they had of what the test was, which is balance when visual surface is altered, as the test shows. And then they looked at their functional walking assessment test. And then gait symmetry and variabilities within that. That's what they were assessing for. The main findings we looked at that we found from this study was it was able to detect differences. All of our clinical tests were able to detect differences between our amputation population versus our non-amputation population. But their conclusion was that's kind of the 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 maximum that these tests can determine for us, and it does not really determine differences within the amputation population that they looked at, the impairment versus non-impairment, sensation intact versus not sensation intact population. So their conclusion from the study was we need to be able to establish maybe more sensitive tests to perform in our clinics to determine the patient's actual somatosensory thresholds post-amputation, to quickly summarize a very statistically complex article. All right. Do we want to do the appraisals kind of in between or go through?
Yeah, why don't we do the appraisal for the article now, and then we can just move into the second
Okay.
article.
Sounds good. Can pull. Are you guys seeing the appraisal sheet on my screen?
No.
Yeah, you have the discussion here. I'm not sure if this is the appraisal sheet.
No, it's just showing that sheet. I can share that too. Still not up?
No.
Mm-mm.
Okay.
If you would like, we can certainly keep that screen up and read the questions off as we go from the.
Yeah, that's essentially what it is. I can kind of run through it too. Over here I have it, but I don't know. Okay. So looking at the results. Um,
Yeah, you can probably just go one question at a time through the appraisal sheet if you want to share the screen for the article itself, and we can just go through the individual questions, even if you don't have the questions up on the screen.
okay. Let me pull.
And I can talk through the first question as you're getting that pulled up. So, are the results of the study valid? First question basically was the defined representative sample of patients assembled at a common point in the course of their disease.
Yeah, there you go.
Yeah, I was able to pull that up. I think the results were valid for this article as I went through it based on how it was set up. It to get more, I'm sure the other questions will cover it. The limitations of this study are more statistically and assessment focused, but the results of what the study was looking to do, I think it established that pretty straightforward.
And we just want to scroll down to the critical appraisal for prognostic
Yep.
studies. Yeah. Yeah, and I agree with that. I think basically this would be something where this was assembled post rehab. prosthesis using Stage basically as a community ambulator. So caveat would be that the time since the amputation varied, but that probably would not significantly affect the outcomes.
Hmm.
Okay,
Yeah,
perfect.
as they had mentioned, age and gender matched as well, I think was a big aspect and a big positive of this study. But yeah, to your
Yeah.
point, I mean, to not have a kind of a linear idea of exactly where somebody may be within a post-amputation type of course, that is certainly a limitation. In addition, obviously, just to the very low value of patients within the study. But yeah, age and gender match, I think, was a really big positive for this one, and I think really validated at least the information that we got from that small group for sure.
One thing I did also kind of notice about this study is there was no direct comparison. I mean, obviously you can't compare within that specific group. It was more of a statistical look at it. They compared the two controls, but within the sensation group, there was I don't think they directly matched in a sense. So it was a lot of reading into the actual methods that really made this interesting to me.
Yeah, and it's certainly lopsided between the um, amputation group, which was the above knee amputations. There were 16 patients, and below knee
Yeah.
with four. So obviously
Right.
very lopsided in that degree, but take it with a grain of salt.
Right. Okay. I think that's good. Like we talked about follow-up sufficient. That's kind of what made the prognosis of this difficult is we don't really have follow-up making it observational.
Right.
Um, we didn't cover this. Okay. All right. So for the outcome, I think is more cross-sectional. There was no talk of blind per se. Um, does that sound about right for everyone? I didn't. Um, and then within the
There was
subgroups
no
we talked
blinding, and
about.
this is what, like you said, it's an observational study, so there was no
Yeah.
blinding or direct comparison for blinding purposes.
Yeah, and
And
again, these were quantitative measures that they were looking at. So, hopefully that really limits detection bias around this, even with it not being blinded. So, yeah.
in our subgroups here, we discussed kind of how they were broken up. The subgroups, like I said, they were compared 20, 20, 20 control matched by age and gender. Another thing is they really it would have been nice to know the comorbidities that were involved with some of these patients. I mean, some patients could have been very sick. Could have It's hard to kind of match for that with your control. How advanced, just looking at age and gender, yeah, that gives it the ability, but that's assuming everybody's mobility and pathologies were the same. Whether also, where the amputation face vascular trauma versus, other things.
Yeah, and certainly I think in matching in that way, whether you're using what we use oftentimes, the Charleston Comorbidity Index is certainly very valuable to give yourself a little bit more of a level playing field from all of your enrollees. But that certainly does introduce quite a lot of confounding factors as well. So again, kind of positives and negatives, and at least in my mind, that they didn't include that as parameters for what they were looking at. But one of the things as far as inclusion criteria that I was a bit, I'm not sure, confused on, or just something that I just didn't have a lot of information from the study was their inclusion for ability to stand unassisted for 10 minutes, uh,
Yeah.
ability to ambulate. And again, and we run into that, and that was actually one of the reasons that, we picked this study is, for your inclusion or exclusion criteria, especially when you're evaluating things that have so many confounding factors. I think the more specific that you can be, in your inclusion exclusion criteria. So just ability to ambulate for me seems a bit generalized. I think it would need to
Yeah.
include something where these are individuals who can ambulate unassisted,
For
or
a certain distance.
for
Yeah.
certain distance, or that they are household ambulators versus community ambulators. I think that becomes a lot more specific. And again, we take as much as we can away from a very small sample size, but that would probably be one of my major critiques for this is that can kind of narrow down both your the size and kind of the contours of the groups of patients that you're picking, as well as the information that you can elucidate from it.
All right.
Good.
And the result. Sorry, go ahead. I think that's about the gist of our. All right. Do we want to go back to our slides and run through the second article here?
Yeah, I think we really hit these questions well.
Yeah.
I think overall, and again, one of the reasons we selected this paper overall is, at least from my appraisal or kind of my critical appraisal of it, is that as far as how they perform their statistical analyses and how they group these patients, to me, blatantly was very confusing. I didn't understand fully exactly how they were evaluating these patients, and I think their manner of articulating the information that they were drawing for this was underwhelming to me. So not to say that the overall structure of the study was poor, but I think the information that we took away from it and the conclusions that we can draw, especially with a very small patient group, 20 patients versus a 20 patient control, where we're just purely, like you said, we're just age and gender matching. We're not matching for activity level. We're not matching for comorbidities. We're not matching for even specific types of amputations. Again, I think that this was a useful study, at least to identify that some of the parameters and measures that we use to evaluate people from a function standpoint needs to be improved. But I don't think that this really answered any of those questions for me in particular, other than to say that perhaps some of these parameters are just not as useful as we want them to be. Which again, if that spurs on additional studies that can actually answer that question, I think it's useful. But I would say, at least from the information that's actually presented in the article, it wasn't something that was extraordinarily useful for me.
Yeah, I would have to agree with that. Like I said, it was a lot of statistical part. There's an attached PDF to this article as well that kind of explains some of them. It tries to explain some of the methods, but I still don't think that it was thoroughly done. Um, so
Yeah, but
for
even as we've discussed, I mean, there's still utility in reviewing those
yeah,
type of
absolutely.
articles and that type of research. And I think that it really kind of comes down to the nature of these journal clubs, is understanding that regardless of, the benefit or detriment of these articles, reviewing them in a critical way, provides us just a little bit more insight as far as the quality of research that we're trying to pursue, as well as what we're taking in and what we're kind of consuming from other specialties or from other countries and kind of around the world.
Speaking of other countries, so
Yeah.
this article, our next article is from France. It's impact of amputation level on gait disorder in transfemoral or AKAs and transtibial amputations. Similar. This article is somewhat similar, but I think it does a little bit of better job in terms of kind of painting a better picture and explaining the criteria that we're talking about, the inclusion, exclusion, and so the article looks at amputation levels. So it groups things specifically, AKA versus BK, and their effect on gait disorders. We'll talk about more what that means. Um, the context of this, the importance of it, generally speaking, in practice, I would say, is they were trying to look more towards how we tailor the rehab that we, the interventions that we have for these patients post amputation. Once they get to these stages, are we rehabbing our patients appropriately based on their amputation types? It's just for context for practice. So the study, retrospective, single center study, 49 unilateral amputees, 22 BKAs, 27 AKAs. They were compared to 30 able-bodied controls, and then they gait measured using such. And then they looked at the most important components or factors that were looked at here were step width, double support time, gait speed, asymmetry ratios, and then the center of pressure displacement. Right. So, to look at our results here, look like the AKA amputee group showed a wider, sorry, hold on, let me like to see. And like I said, what they did was they looked at all these things using the gait assessment parameters that they have listed here. The results showed that the AKA group had wider step width, increased double support phase, and slower walking speed. The interpretation of that is they have a little bit more cautious gait behavior, and then there was a greater asymmetry um, in the higher amputation level overall. Um, I would say they looked at it and they looked at it became asymmetry wise, it's able-bodied to transtibial to our trans femoral amputations. And then our conclusion from this study is the more proximal the amputation, the more asymmetry we're looking at, the more lateral instability, which is our center of pressure that we were talking about. They have more cautious gait, and they heavily rely on their contralateral limb is another um, thing that we can kind of conclude from all this. And the rehab should be a little bit more tailored based off of these findings is their final conclusion. Right. Then we can kind of run through the same appraisal. I can pull that back up if we need to. So the inclusion for this one, I remember specifically, is they needed to be able to walk about 20 meters. So this one just had a little bit more um, specific parameters in that sense. I think that was the biggest factor, be able to stand. But other than that, I think they were just um, their control matching was about very similar to the previous article, not going too
Yeah.
much detail.
I don't think this one was matched
It was
for age or gender, unfortunately, as far as their comparison. Obviously, there's limitations with that, but that was one of the big things, at least in comparison to the previous articles, that there wasn't specific matching, or I should say age matching. And I think the big thing for that is, I mean, and as is mentioned previously, and I think is alluded to in the previous article as well, is that we know just from universal studies on gait analysis is that as we age, there are differences that occur even normally
Mm.
within gait. So I think that was a big miss as far as some of the information that we can take away from it. Not that it's not valid, but I think it was something that when it comes down to matching overall, that an age match in these types of groups would have been really beneficial.
The one thing they looked at is the spine. They looked at it like an ANCOVA adjusting. I think within the study, that was their closest thing to whatever you call matching. They looked at spontaneous walking speed is something they try to within the groups. I don't know what that means, but that's something they looked at. Um,
Yeah, there was quite a significant number of areas, and they had gone into several descriptions of a lot of the statistical analysis and statistical manipulations based off of confounding factors and inability to match. But I do think
yeah,
that as much as they tried, that could have been very easily remedied just with age matching within these groups,
yeah,
especially if you already have matching within your amputation groups. Then matching within a control group should be that much easier conceivably. But yeah, certainly future studies to kind of look at that. But that was one of the big things I think that I looked at as far as just the overall structure.
mm,
But like you said, I mean, they had a much more specific manner as far as measuring gait with their gait platform.
yeah,
I do think that the way that they measured that, which again, similar to the previous study, they had asked patients to walk at a self-selected pace, which
mm,
again, without having a specific description of how patient might be prompted to say, I would like for you to walk at a self-selected pace.
yeah,
Want you to walk like you're walking down the street or walking in your house. There's so much variability that a person could take away from just saying, I want you to walk how you normally walk, or I want you to walk how you
mm,
self-selected manner. So I think some more detail on that would be something that I would even just ask the authors as far as how they kind of elucidated that from their patients. But that was kind of a big one for me as well.
yeah. So that kind of brings a point to the validity of, or looking at our appraisal. Things that I looked at was the possible selection bias when you're looking at selecting your kind of amputation patients. Are they high functioning patients? Are they, because you're asking them to walk 20 meters. There could have been some, you're not looking at, raw post, amputation patients that are, ready to go. You're looking at somebody who's able to do a specific task that you're asking them. So that's selection bias by looking at high functioning amputations. Is kind of what I looked at. And the other thing,
And to that point, and even to expand on that, exactly that is that we know as far as procedure selection, obviously can
yeah,
be motivated, perpetuated by things like ischemia and infection. But another decision-making option when you're talking about these types of procedures is a patient's functionality. And someone who has an above-knee amputation does not have the expectation to be as ambulatory or as
Mhm.
functional as someone with a BKA, generally speaking. But absolutely, I don't think that we're necessarily comparing apples to apples here. And, when we don't have like an exact match overall, it can certainly muddy the waters.
Yeah, and also to build off of that is the varying amputation dates. I think it's very important to establish how long in there. If you're not going to do a longitudinal study, I think it's important to establish at least the the where the patient's timeline is in terms of, are they just it's getting established in their prosthetic? Are they someone who's been walking in this state for a while? It's important to kind of, those parameters matter, as we know from our clinics, how a patient handles the part they're in the timeline. That's good context to have when you're assessing these kind of situations.
Yeah, great points. And I think we're really hitting a lot of the responses in these questions here. But with the first question, it was the defined representative sample of patients assembled at a common point in the course of their disease. I'd say for the most part, yes. Now, I don't know that they nailed down exactly if they were at the same point in the rehab process or the time since the amputation. So, whether that could be a variable that could contribute as well. But overall, I think we can answer that question largely yes.
Mhm.
Second
All right.
question, is patient follow-up sufficiently long and complete? Same as
Uh,
before.
Same thing as the last one. There was no follow-up. You're looking at these patients at one point in time. You're looking at a specific test done at a specific time. Like I said, that's why we're kind of timeline so important. There is no follow-up here to look at these patients. Why it's not a prognostic study. It's more of observational study.
Yeah, but to that point, I mean that's a great idea and certainly a great criticism for this paper or future papers is to follow patients in this manner
Yeah.
longitudinally, especially early and mid and late kind of follow up after these types of procedures, and if we're able to match for comorbidities and age and gender, that really gives us a much more reliable comparison for the information that we're gathering for sure.
Yep. Said. Were outcome criteria either objective or applied in a blind fashion? I think there's some similarities with the last study with a couple of these questions, but yeah, go ahead.
I think yes, that's same thing, same kind of discussion is like we talked about earlier. I don't know if there's some bias, selection bias, whether it's function, things that we previously discussed. There was no talk of specifically blind per se, but there's a little bit more inclusion criteria, specific inclusion criteria that were discussed here versus the last one, but I still wouldn't say blind.
Yeah, and inherently that's a limitation, I think, to our profession, to be honest with you. I mean, the limitations that exist unless we're performing prospective studies and comparative studies, then blinding in any manner is going to be that much more difficult. But yeah, as you had kind of mentioned, not necessarily the level or the nature of these studies overall.
Yeah. Right.
Okay, if subgroups with different prognoses are identified, did adjustment for important prognostic factors take place?
Um, I mean, the subgroups that we looked at, they were they were kind of assessed appropriately, I would say. Um, Adjust, like we talked about, they were adjusted poorly in a sense, with the only thing being, the walking speed, a statistical ANCOVA adjustment that I was randomly able to pick out of, a lot of statistical analysis that was done. I the two groups that were compared, I think we could have done a better job, like Dr. Atves just said, just comparing using a little bit more criteria to kind of adjust the groups. Comorbidities, like I said, it's a big one. Age and gender is kind of almost like base what you should do. Just the um, at least starting point. I think it's a good point to make.
Yeah, well said. And it seems like maybe this paper did a little better job than the last with some of those prognostic factors, but certainly some uh, potential for ongoing confounding issues there.
Yeah, a couple other things too that I just realized I wrote down that they definitely could have adjusted for is prosthetic type is a good one, and BMI. I think those are two factors that we definitely are worth discussing. That you can make studies just based off of looking at those specific adjustments, I think. But it's another thing about looking at things like this when you involve functional things to assess after pathologic treatment. You look at these functional things and there's so many different ways to go with it. I think it's kind of difficult to find the right thing to adjust to, depending what you look at. But I think that overall they're all important for our clinical assessment, which is why I think the study is so important. Is it helps us establish the next step, which is our rehab for these specific patients.
All set. What are the results? I know you hit some of these questions already. How
Mhm.
likely are the outcomes over time?
Like we said, they're not looked at over time. I think these results are important. I think they definitely do establish an association, but they do not establish any prognostic um, information that we can kind of use to, make a hard statement. If this and this, I think it's more of just kind of things to take into consideration. If you don't, you just can't, you can't claim that without your longitudinal look at these patients, especially with all the things that we're missing that we just discussed. But I think it's a good association to use in our assessment of how these patients are rehabbed. Something as simple as proximal amputations are more likely to have asymmetry, more likely to be unstable, all these different things, lateral, more reliant on their prosthetic, on their contralateral side. These are all things that are good to consider and know, but they are not per se fact for this patient population. It's association versus prognostic statements.
How precise are the prognostic estimates?
We'll say that again, sorry.
Next question, down on the next page, how precise are the prognostic estimates?
Yeah, I mean, certainly only so much we can take away from this. But again, we did see statistical significance in the outcomes that we saw, and obviously, even though this was a larger sample size versus the previous paper that we reviewed, it's still a very small sample. But the fact that we saw this corroborated within the literature, the changes that we see, which essentially these gait abnormalities or these gait pathologies are essentially compensations that these patients are undergoing. I would see that the validity of this information is quite high, and I would take a lot of the information from this much more so than the previous study, just based off of the study design and honestly the articulation of that information. I think was really quite useful, but certainly expanding on our sample size and matching to a certain degree would provide us just much more confidence, I think, overall.
I would
Yeah,
agree with that.
right. They seem to do a little bit of a better job from that perspective, including confidence intervals and a lot of those other factors like you mentioned. Now, can I apply this valid, important evidence about prognosis to my patient?
Yeah, absolutely. I mean, like I was saying, it's kind of the whole point of this paper. I think they knew what they were doing in terms of are they really going for prognostic cohorts to study? No, they're looking at specific parameters that are very useful for us and very valid in the way that they did it for us to establish like their whole purpose of the paper, aim and objective, like I said in the beginning, was to establish the rehab parameters for these specific amputation patients.
Yeah, well said. I think Dr. Ramdas said you want to jump in and make a couple points as well.
Yeah, so thank you guys for having us, and thank you for having Spica sponsor this. Great review. I think we often do limb salvage in our profession, and we can see from those two articles what can happen when limb salvage fails. So, from a medical legal standpoint, I think 2 points I'd like to make is one is when you're going to treat these patients, I think having them go to rehab, we call it prehab, having them go to physical therapy prior to see what their functional level is prior to any type of amputation is critical. Making the necessary consultations. We know these patients are very ill and sick and have multiple comorbidities. So I like to use the acronym VIC, call VIC, vascular infectious disease and cardiology, because we know these patients usually have cardiac issues, vasculopathy, and if there's any infection, we need to have this experts on board, and physical therapy. And then the last thing I would say is talk about amputation as a result and an option, because you want these patients to have realistic expectations and you want to document it appropriately. So tempered expectations, make the necessary consultations, and have the necessary resources. If you're going to do these big limb salvage cases, make sure you have your fellows and your partners who can come in with you, because these are very challenging cases, and we're seeing it from our end when you're trying to do the best, and we it still gets to a legal case and so on. So we just want to advise the audience to ensure that you make the necessary consultations, do the necessary documentation, and you can offer amputation as an option. As you can see, when you do have amputations, the prognosis is not that great, and these patients' quality of life is affected. So thank you guys.
Of course. Well said. Thank you.
Yeah, yeah, I think those are points that are pertinent to every one of our practices. So excellent points to be made. Um, so with that, we'll move into the next portion of time here and give Dr. Atves and Dr. Louzati some time to talk about the fellowship.
Yeah, thank you. And honestly, again, thank you so much for the opportunity to, review these articles and really talk on almost any topic. Our fellowship at Georgetown is one, and Dr. Louzati's in the midst of it right now, that really offers quite an extensive amount of flexibility. And what I mean by that is our fellow really does not have any specific or mandated days in clinic or days in the OR, so to speak. Really, every single day is really kind of at the disposal of kind of their interests and what they want to accomplish. Certainly, we are relatively heavy from a research standpoint, but as Dr. Louzati will tell you, he's in the operating room several days a week within our clinics, interacting with students, whether they're podiatry, whether they're from Georgetown or across the country, and just interacting with a number of individuals within our health institution and Georgetown University. But really the topics of today's articles was really a little bit of an insight to my own personal interest, and I think what's become a very vested interest for our team at Georgetown, and that really is ambulatory function of every one of our patients. As Dr. Ramdas very well said, that really any surgery that any of us perform always has the possibility, heaven forbid, of an amputation, whether it's a toe or leg, and anything in between. So I think understanding and not really deferring or avoiding those conversations is really important. But really, again, the topics of these articles, I think really kind of show us that the information and the interest in understanding how people ambulate and how to best enrich their lives if they have to unfortunately undergo something to that effect is something that is unfortunately very poorly supported in our literature, and I think is something that needs to be an emphasis in future years, specifically from podiatry, about how people walk, how we can maximize function, and how we can avoid complications or compensations. And again, that's really kind of the basis of our team, and in some degree is really the basis of our fellowship overall. But again, very happy to be here, really happy to kind of put our name out there every year with these types of journal articles and other types of activities overall. And again, if you have any interest, feel free to reach out to myself or Dr. Louzati. We're happy to kind of have you out or talk with you through the opportunities that are available. And again, thanks so much for having us.
Yeah, thank you. I can do my best to add on to that. On a day-to-day basis, honestly, it's great autonomy here. That's kind of one of the biggest things that I chose this fellowship for is if you want to see everything, if you want to kind of do it, not essentially do everything when you're done, but just kind of have an awareness of what's going on out there. I think this is a great place, whether it comes to opportunity and resources. If you want to do research, 100% sure. I mean, this is perfect place to do that. Also, if you don't want to do that, you just want to be able to do research and know how the process works and see how you can get an idea all the way to paper, published, posters, all that. This is a great place for resources. If you just want to see really complex cases that go crazy in every single way possible, this is the perfect place to do that. Whether it's limb salvage, whether it's ortho, whether it's like Dr. Atves said, I'm in the OR pretty much 3 days a week, I would say. 2, 3 days a week for sure, every week. And that's just because I like to see my patients through. I like to kind of see the case through and through. And now I'm starting to see the end part of these cases that I did, in the beginning of the year. And they're very complex, a lot of revision cases and things like that. Doesn't necessarily mean I want to do that when I get out of here, but having that idea and having a visual of what to do in those scenarios and then coming to case presentations with Dr. Atves and all the other departments and discussing those, that's great to have as a provider for your patients in the future. And I think this is a good place to see everything through and through from your healthy outpatient cases to your, chaos revision of the revision patients. So anybody has any questions?
Well, great. And keep up the great work out there in DC. Sounds like an excellent program. Just want to thank once again Dr. Atves, Dr. Louzati, Dr. Ramdas, and Paika for your support. And make sure that you mark your calendars for March 19th next month for the Journal Club. And hope to see several of you at the ASC next week.
Right.
Right.
Excellent. Have a good night.
Good night.
Thank you for having us. Take care.
Good night. Thank you.
Thank you so much, doctors.
Yep. Bye.